So my talk's going to be a little different. I'm going to talk about a whole medley of projects, not just one specific one. And really the overarching theme is going to be scaling access to care. So that's the overarching theme. And really the underlying theme is, pushing kind of, or what is the promise of digital health? How do we get to the promise of digital health? And what does that even mean? So there are many definitions of digital health. One definition would be, that digital health is a convergence of patient data, connectivity, and compute power to increase access and provide personalized healthcare to improve outcomes at a lower cost. And so really the tailwinds, what kind of led to the opportunity for all this really started in the early 2000s with the introduction of the smartphone, as you see in the diagram there, maybe wearables with sensors. And then in 2009, you had the High-Tech Act, where over $20 billion was infused into the healthcare system as incentive to digitize your electronic health records. So really, those are the early days and kind of provided the opportunity for kind of this great marriage and between computer science and medicine. So interestingly, we spend, and I'm sure everyone's heard this, but it's always fun to think about, we spend less than 1% of our time in the doctor's office and over 99% of our time outside of it. Yet most of the money and focus in healthcare is on that 1% of time you spend in the hospital, in the clinic. So, that begs the question, what are some opportunities, maybe being a little more predictive, preventative to engage people outside of the four walls of the hospital and affect their health in a positive way. So this is just, it's always good to have a framework. So, again, just thinking back to what does digital mean, and it can mean so many different things, but from a data standpoint or data resources or data sources, it really starts with the patient, you, the consumer, and your interaction with the health system. It could be, hospital, clinic, pharmacy. I talked about devices, wearables, smartphones, whatever. And then there's tons of data. There's a challenge always in structuring that data. So you have that data layer where you have to kind of structure it and understand what that data means, the ontology, and so on. And then there's the important analysis that needs to be done, which can be done by computers, humans, whatever. And that's where you get the insights that can then feed back to the health, the whole ecosystem, and provide value. So there are two buckets that I'm going to just quickly run through a few projects for, and one is still focused on the 1%, the hospital workflow. Where can we help workflow in the health system? And then where I think there are huge opportunities is connecting with the patients outside of the four walls of the hospital. So we'll start with some interesting workflow ones. And as a vascular surgeon, I'm going to be focusing on some vascular projects that kind of plagued me. And one of them is, getting an ankle brachial index, for us to get referrals from primary care doctors, podiatrists, or, wound care clinics. There's always that hurdle of like, well, what's the blood flow like? They can listen with a Doppler, but often it requires an ankle brachial index to be measured at some vascular lab, and that can cause a 2-week delay. And we all in the room, we've all used Dopplers, and I think we get a good sense. We can probably hear and appreciate, like, "Ooh, that sounds like really good. It's triphasic," or "That sounds monophasic or biphasic." And so what we did with this quick project was just to train a model, just to listen to the sounds and predict an ABI. It was called Auto ABI, and it basically listens to the Doppler sound as you're measuring the Doppler, and it gives you kind of 3 bucketed results, normal, moderate disease, or severe disease, so that it can help you with the triaging and the referral at the point of care. And the really cool thing is that nowadays you can run this stuff on device. You don't even have to send the sounds to the cloud or anything like that. So that was another really fun feature. So that's one project. Another one I'm really excited about, there are over 20, or the most common CT scan that we obtain in the United States is the abdominal pelvic CT scan. And there are over 20 million of these done. So why not, little echo. Why not look at all these scans and in an opportunistic way, what if you could have a system just sitting in the background that's kind of scanning or looking over these CT scans as they're being read, and for the radiologist kind of spits out, like if there is an aneurysm, it'll say, hey, it'll flag it and say, there's an aneurysm, and by the way, it's this size, and you get this nice little image, with the diameter, with the slice number showing how it measured the aneurysm. So this is a really amazing thing. There's a lot of work on this being done at the Stanford Amy Center. I highly recommend you look them up. And I mean, this was so advanced, we're actually submitting for 510(k) approval this month for this algorithm. And it's all open source. You can go to Hugging Face, the model is there, you can upload your CT and it'll provide it. The challenge is the workflow integration. Another fun project that also I think everyone in the room here can appreciate. We all have to put in central lines, right? Whether it's venous or femoral for us, it's very hard for me, I'll be honest, it's hard to kind of use patients to learn on, especially with large bore arterial catheters and so on. So this is what led to this project. How can we create a training module where you can get your reps in? Because let's be honest, it's pretty challenging to triangulate where the needle tip is, where the ultrasound is probing or pointing to, and where the vessel is. And everyone's different. Thin patients are easy. Then you have patients with, where the vessel's deeper. You have calcifications that you have to avoid, things like that, at least on the arterial side. So can we create a training module to kind of, just to help with the training of this? And you can do some pretty amazing things, and the fidelity on these headsets and controllers is incredible. And we even created this cool, 3 different rooms. You actually start with a transparent body where you can actually see the vessel, so that, you can put the probe where you expect it to be, based on the landmarks, and you can see the arteries and veins and inguinal ligament. And then you can go through the rooms, the intern room where you have a thin patient, the resident room with a slightly larger or bigger body habitus, and then the chief room, which is the hardest room. And you can, have these levels of difficulty. And here's an example. The really cool thing is, as you're moving the probe over the vessel, you can actually get some guidance in the training room, like, oh, it's safe to access the artery here. That's the femoral artery that's green. If you go higher, you're in the external iliac, or if you come low, that's the femoral, so don't puncture there. So there's some really cool things you can do in training people in this with, vascular access. Let's see, let's keep moving. Okay, now we're gonna move to kind of an area I'm super excited about, and that's connecting the patients outside of the 4 walls of the hospital to really extend care. And even the NIH, knows this is and this is an opportunity, and made this statement that digital health innovations can democratize access to healthcare by providing tools and platforms that enable remote diagnosis, treatment, and management of health conditions, making it possible for more people to receive care regardless of their location. And so, this addresses rural issues, access issues, all kinds of issues, potentially. There are many, many challenges, but one of the projects I worked on, like initially for years, and we even did a national multi-center trial on, is just providing, it's a great example, home-based exercise therapy for vascular surgery, level A evidence, grade A recommendation, utilization in the toilet, nobody's using it. And part of the reason is it's tough, like what patient wants to come to a place, find parking, like to come to a health system, where these rehab centers are, where they're typically run, pay for parking, all that stuff, to just be on a treadmill with a therapist. And so there's an opportunity here with health coaches to do this at home. So we ran this trial and had, very good results. The biggest problem, I'll admit, with a lot of these offerings is that because, the healthcare system in the US is set up to pay for doing things in the health system, it's very hard to get these reimbursed. So that's probably the biggest challenge. It's never the technology, it's finding a good reimbursement model. So that's where I have the most wounds in my body. This is another just interesting take. Like, what if you know, we're so focused on the high value event. You know, for us, for example, putting in an endovascular endograft is, you know, high revenue generating. It's a, you know, it's an incredible procedure. People go home the next day. But the reality is your journey when you're diagnosed with an aneurysm starts much earlier. You know, Dr. Dalman is sitting here in the room. He's doing a study with metformin, you know, on small aneurysms. So what if you, instead of just focusing on the, you know, the high value event, you know, you created, you know, get the patients more involved, create this like passport for whatever condition you're focused on. Because as soon as you're diagnosed with that aneurysm, that's kind of where the interaction engagement can benefit. You know, you can do better coaching and medication management, smoking cessation. For us, what's really important is the surveillance, making sure you're getting your annual surveillance, charting the growth of the aneurysm. And that doesn't end after the graft is placed. Even for us, with these endovascular grafts, you know, you can have type 2 endoleaks and sac growth and so on. So surveillance after placement is super important. So I think there's a really good opportunity to capture greater value, provide a better service, you know, for the patients as well, and better experience if we thought a little more broadly. This, you know, since I mentioned the 2009 HITECH Act, well, in 2020, we had the 21st Century Cures Act, the final rule. And really what that did, it mandated that, you know, every health system, including Stanford, if you have a certified EHR, you can get your health records on your phone. I don't know if everyone here probably has MyChart. I don't know if you ever downloaded your records onto if you have an iPhone, into the health app of iPhone, you can do it in 2 minutes. Like all your records literally on your device with you. And you can now take these FHIR resources that are on your phone and run it against an LLM and translate, you know, allow people to have conversations with their health records. You know, what happened during my discharge? What does my radiology report say? Things like that. So it's pretty incredible what you can do when you think about accessibility and improving engagement. So this is a really exciting project that we're working on. Obviously, when you talk about LLMs, it's not very, you know, people freaked out initially, like, oh my God, you're sending all your health records to OpenAI? Like, you're crazy. I'd never do that. And that's true. You know, there are concerns with privacy and security. And one way you can address that in an area of research we're working on in our lab is something called, you know, local or fog computing. So instead of sending the data to the cloud to OpenAI, what if, kind of like Stanford has its secure GPT, have you guys worked with that a little bit? It's in contract with Amazon Azure, but it's still kind of isolating where the data is going. What if you ran everything on your phone, you know, with smaller models? It's not only cheaper, but it's more privacy preserving. So that's the kind of really fun research we're doing there, which is really cool. And for this group, you know, for us, I've been doing this for so many years that I've had a lot of people come to me and say, I want to do a digital health study, help me get from 0 to 1. And it's really challenging. I would always say, well, you got to spec out the project, find a developer, pick a front end, pick a back end. And so we tried to make that a lot easier by just creating an open source framework called SPEZI. That's what's up there, SPEZI Open Source Mobile Framework. And, you know, we leverage that in a class we teach every winter quarter called Building for Digital Health. And that's an image from last year. And we've built probably 20 projects here at Stanford. And we work closely with IT so that you get kind of a TSA pre-check, you know, if you need to go through the data risk assessment and so on. And this year, Dr. Pratt, one of her projects was submitted that we're hopefully going to be able to support in the class. So it's one way to, you know, engage with us and to, you know, do work in this area, which I think is super fun. And so feel free this is kind of a small portion of our group. You can look at the SPEZI website, look at our lab website, and that pretty much covers it. So thank you very much.